One of the entities that we are looking at under the cost growth benchmark are what we are calling advanced networks here in Connecticut, which are large physician groups. And we did do some analysis of the benchmark with advanced networks, and we learned a lot. We had a lot of good conversation, and we learned that we have some more work to do with our partners in the health insurance industry, with our ANs, to make sure that we have the attribution models down correctly, that we are all on the same page about which cost to attribute to which advanced network, and how to measure the benchmark going forward. So we thought maybe for this first year, what we would have to do is have more of a roundtable discussion with our advanced networks around affordability. You all are on the front lines. You're working with patients every day who are facing affordability challenges. And you're also on the ground for some of these advanced payment models that we were talking about in the prior session. So we're really anxious to hear what you have to say. We're delighted that Anna Duragasi is going to be moderating the panel this afternoon. Anna is with the Connecticut AARP. She is the State Director of Advocacy and Outreach. And in that role, she manages volunteer teams and advocates for policies and practices that support family caregivers, improve access to long-term care, creates more livable communities, and helps people choose how they live as they age. She came to AARP Connecticut from Albany, where she worked on nonprofit policy issues for the governor's office in New York, in the Division of Budget. And she was instrumental in launching the nonprofit infrastructure capital investment program, which awarded more than $100 million in grants during its first 2 years. So I'm going to ask you, Anna, to ask the panel to introduce themselves. So I'll turn this over to you now. Thank you.
Great. Thank you so much for that nice introduction, Dr. Gifford, and for letting me participate in today's hearing. And thank you also to Abby and the folks on your team who did such a terrific job of putting everything together for today. So before we really jump in, I was chatting with some of the panelists just a moment ago, and we talked a bit about how today's hearing has really surfaced a lot of areas of disagreement. You know, what is and is not a driver of healthcare growth, whether the benchmark report uses the right data sources, which industry is most responsible for growth, and so on. And maybe this is overly optimistic, but I think there are also a lot of flashes of agreement that have come up throughout the day. So agreement that there's not as much transparency as we could have across and within healthcare industries. Agreement that we need to pay more attention to social determinants of health. And agreement that there are real consequences when people avoid care due to cost. So I'd like to use these areas of agreement as the starting point for a conversation to explore possible solutions. And I really want to make sure that this last conversation of the day focuses on what I hope we can all agree is most important, and that is consumers like Margaret, employers like Chris, and the Connecticut residents and families who are bearing the brunt of rising healthcare costs and who are literally dying for us to improve healthcare access. So Dr. Pardon, during the earlier hospital panel, you said we're trying to figure out what is actionable. And I'm hoping that this last conversation is an opportunity for you all to talk about what your organizations are doing to help real people access the high quality care they deserve, and also what more you could do. So I want to hear your ideas about how we can be more innovative, how we can address disparities, and how we can build a healthcare system that is sustainable and that can meet the changing needs of Connecticut residents. So with that, let's start with just brief introductions. We'll kind of move from my left to right. So just a quick explanation of who you are, why you're here. And as part of that, could you please just mention how are high costs impacting the patients that you and your organization see?
Jim Carter. Jim Carter, non-invasive cardiologist in practice here in Connecticut for the past 30 years. I'm going around healthcare as Executive Vice President, Clinical Innovation Officer, responsible for really participating in transform the delivery system to meet some of the goals that we articulated. That's what I was going to. From our perspective, healthcare is not only impacting patients that we take care of, but has a significant impact on the overall economy of the state, and we're going to positively continue to make choices, difficult choices in terms of how they can afford to make sure that they are doing what they need to do to stay healthy and to receive care when they need it, with other important things like how do I make sure I have to eat. We have various levels for a wealthy state of our ability to meet the needs of all of those things. And so our focus is, as the aspiration of this entire initiative, is to really begin to figure out where and what are the interdependencies that are driving that overall cost, and where can we insert ourselves in all of our various responsibilities, start mitigating the most on. It's difficult because there are many drivers and they all don't have the same impact. We've got to figure out how to identify, prioritize, and then come up with action steps. I appreciate that.
Good afternoon, everyone. Thank you for the opportunity to be here. I'm Joe Fronta. I am a primary care physician. I've been in practice in Brantford, Connecticut for a bit over 20 years now. I also have a couple other roles. I had the pleasure of being the president of Pre-Medical Group as well for the last 10 years. And in recent months, I've also taken on a new position as the market president for Privia Health Connecticut. And our organization, Pre-Medical Group and Privia Health, formed a new partnership here in Connecticut just recently. And I have the pleasure of leading those efforts here in Connecticut. And just a brief summary of what our organization really is about is we're an organization that is committed to supporting independent physicians and providers. We do that in many states across the country, and the key focus is that we try to meet our providers where they are. We try to maintain our providers' autonomy, our providers' independence, as we feel it's a really important part of the healthcare delivery system that provides value to patients and to the delivery landscape in general. But we realize that our providers, especially our independent providers, need a little more help than they can do on their own. And so our goal is to really try to bring best-in-class technology, best-in-class infrastructure, best-in-class support, particularly around value-based care and improving quality outcomes and patient experience to those independent providers. So that we find a mix in the best of both worlds, an independent clinician experience with the large scale resources that you might find in a larger organization. And again, with that key focus on driving the transition over to value-based care. And in our model, our physicians remain independent. They continue to own, control, and manage their own groups and practices. And very importantly, they really play a major role in the governance and the direction of our organization and what we do. It's really great to be here. Your question was an interesting one. And one of the difficult answers is that there are far too many examples of the patients who had to make choices about the cost of their care. And that is a daily experience for our clinicians who are facing the difficult conversation of making the choice about the patient's treatment based upon cost and that patient's individual comfort versus what the best recommendation is for the patient. And I think about a patient that I treat for some time now, and it's a very clear example that we're making kind of a decision to treat her in a different way. That is not perhaps the first choice, but the best choice and most convenient choice. But because the cost issue is the choice that we're making. And every day providers are running the gauntlet of trying to navigate that kind of ethical and practical dilemma is how do we deliver what we think is the best care, the first choice of their care in a model though that we may not have that option given that costs are high. And so, one of the things that I think about is how do we drive improved access? How do we balance out the affordability across our patient bases? How do we reach a point where, when a physician or provider makes the best recommendation based on clinical standards and evidence, that our system supports our patient's ability to afford that. And also one final piece is we also then ease the burden of our providers to be able to provide that care without going through severe and significant administrative burdens and red tape over time. And so I think it'll be really great to continue the conversation. I hope to touch on some of these points. Thank you again for the opportunity.
Good afternoon. My name is Lisa Trumbull. I'm the president and CEO of Southern New England Healthcare Organization. We're a clinically integrated network. We operated in Massachusetts and Connecticut. And for a little bit of history about me, about 30 years in healthcare. I started in Massachusetts and spent the bulk of my career in Massachusetts going through a lot of the work that both David and Michael have done over the years there and transitioned a former organization to accepting significant value-based risks in their portfolio. When I started this, my job here at Southern New England Healthcare in January of 2020, it was really fortuitous because it was just before COVID hit. And I knew no one in the state. And I couldn't believe how different this state was compared to Massachusetts. We share a border. We're very, very much aligned in many ways, but it's very different. Healthcare is very different here. Our organization focuses entirely on value-based care. That's all we do. 1,700 providers, 5 hospitals in our network. Nothing but value-based contracting. And what I found interesting that was missing today in the conversation was population health. That there was no conversation around what needs to be wrapped around the patient, what needs to be wrapped around the provider in order to be able to deliver value-based care. And that's what I'm hoping we can talk more about today.
Hi, everyone. Thanks for having me here today. My name is Joanne Bourdoin. I'm the president and CEO for Community Health and Wellness Center in Torrington. We are a federally qualified health center, and we are a network of 17 across the state of Connecticut. So much here has been said that resonates with me personally, having been in healthcare for 35 years as a nurse, and then in healthcare administration. Personally, having had family members go through the challenges of what we've all discussed here as a patient and needing services and needing drugs that are very costly. As a leader of an FQHC, treating the most vulnerable populations in the communities that we serve. Marginalized individuals who suffer from inequities, barriers to care. And so social determinants of health have become really our fifth vital sign in our organization. And those social determinants of health we have seen literally contribute to medical and chronic conditions of patients that we treat. So accessibility, coordination of care, affordability, and above all, though I may simplify what is the solution that we've all been talking about today, but it's been a common thread in many of our discussions, is to really figure out how we focus on prevention. Because prevention is really the key to lessening acuity of care for patients, decreasing ED utilization, and so much more that we touched upon today. And we hope to be a key partner in how we address reducing those costs across the healthcare system.
Wonderful. So let's pick up on that thread, I guess, around this piece around the social determinants of health. And two questions kind of come to mind for me when we're talking about the social determinants. First of all, from the healthcare industry, how far upstream should we be going in this approach? And what are some of the most pressing issues that we should address? Who should address them? Where do we jump in? I want this to be open. I'm trying to be as open-ended as possible because I don't care about my ideas nearly as much as I care about yours. So, Joanne, I'll just throw that right back to you.
Sure.
Again.
I think the important thing to remember is we can't do it ourselves, right? Whether it's one organization, a hospital, a community health provider, an FQHC, we can't do this ourselves. It's impossible. So again, I think what we go back to is, some of the more rural communities have various social determinants that are more prevalent than some of the more urban communities. So for example, in the Northwest corner, we really lack public transportation. And one might not think of that as so critical, but when you can't get to your appointment, it impacts so much of the part of your health, right? So what do? So we strengthen our community relationships, and we hope that by offering patients, vouchers and a place to refer them that's not out of town where you need to worry about driving 30 miles. Bringing services to our health centers so that when patients walk to come see us, they just make that one stop and don't have to go elsewhere. So I think in terms of the reach, it's very broad. And because we, in particular in Torrington, service about 15 surrounding towns, which the further north you go, the less transportation and the more of an issue it becomes. We need to develop relationships and partnerships. And that's one component. And when you're lacking healthcare services, in particular primary care, which is the hub and the spoke of what keeps people well, when you're focusing on prevention, you then also need to think a little bit further of, how do we just give folks access in general and address those social determinants that may prevent them from being compliant. So I don't know if I answered your question in a roundabout way, but there's so many aspects.
I asked the question in a roundabout way, so I think you came at it just right. Lisa, I see your committee.
So, I think we need to go as far upstream as we possibly can. When we reflect on the evolution of healthcare and, not to keep going with like Bush Rebate kind of comparisons, but I, think of Marcus Welby and Will House on a fairly kind of days, right? Where the provider came to your home to take care of you and knew about your family, knew what was driving your family's health and wellness in your own community. And we've lost that sense of community. We don't have the same resources wrapped around our citizens in this country, not just in Connecticut, but in the country. And when we look at the challenges that our patients face on a day-to-day basis, it's transportation, it's food, it's community connectedness, it's social isolation, it's access to prescriptions and, even being able to get to a pharmacy. The list goes on and on about the challenges that patients face every day. And that is not solved solely by a healthcare provider. It has to be solved by a community. It requires the community of individuals that were here today talking about how we can maybe change our purse strings to afford to fund the social elements of what we need to provide rather than just the medical pieces. And I understand that initially has a cost burden until there's some balancing. But when we look at the US, we fund far less on the social side. We spend way more on fixing everything that's broken. And we have to get ahead of that. So it has to start as early as possible with every individual, and it has to be somewhat based in community health and wellness.
Definitely where you're transferring your mind. So, I agree with everything that's been said. I think one of the things that we really have to make sure we're paying attention to is collecting the data. And we have an enormous lack of insight and data. We have an opportunity because although we won't be the solution for all those problems, we're probably going to identify most of them as they come through. And we're going to consistently asking and getting that data up with input. We have no way to stratify our populations to target activity. There's an enormous amount of stuff that we do, and we know that there is various there. This is not going to be discovering a problem. What we need to do is, as we collect the data, have a robust effort to do that every place they touch the system, whether they're coming to the hospital, ED, or primary care or our specialists. We want them to start to ask these questions and then use that data to bump it up against our utilization of our quality around all of those things. And then we can start to release, make really targeted process and work with partners who are going to help us to kind of address it, because it is much broader and stated than providers.
And if I can just tag on to what Dr. Flynn said, it's the data, but it's also the ability to share that data across sectors, communities, states, and I know we're working toward that as a state, but being able to share that, because unfortunately we're not all on the same platform, because that would be the easy solution, right? So there's a cost also that is associated with that, but sharing that data and being able to follow a patient's care is so critical to outcomes. And we need to, things have changed to electronic in a good way, but we need to be able to talk to each other that way then, and we need to make that investment in how we do communicate with that data that's so important to key outcomes.
So just a couple of points. I would echo the comments made about data collection in this area. We've spent a lot of time in the last several years trying to engage our clinicians and providers on this topic and really bring the concept of social determinant of health screening into the daily routine of our clinicians and our providers. One of the interesting things that comes up is that many providers say, we've been doing this for a long time. So a lot of clinicians, this has been done for generations as part of the natural part of practice. What we've not really done is define the terms of the social determinants of health that we want to measure, report, and then act on. And so one of the challenges that we're facing, and Jim, you're alluding to it, is that we really need to have a better model to look at how we collect, report, and then act upon data in this area. And right now, I think there's a little bit too lack of definition. The systems are not in place to do it accurately and to do it well. And I think we've not even agreed amongst ourselves what some of those terms and some of them definitions should look like. And as we start to think about asking providers to perform in this area, I think that's even a further step where we've not even defined what we're asking them to do going forward. And so I think it's incumbent upon the collective of us to really think about that and work upon that area. Because what it leads to ultimately that we're trying to do is drive outcomes and drive change in patient care. So the second point I'll make is that I think that we really have to understand that asking about social determinants, collecting data on social determinants is one thing, but we need a systemic mechanism in place to act upon the social determinants across the entire spectrum that we find. Some of those tend to reside in more traditional medical systems, for example, behavioral health access. Some of those tend to cross over, I think, to areas that have not traditionally been part of the healthcare delivery system. Either way, if we're going to identify social determinants as important, we have to give our providers and providers the tools to solve this. And honestly, we don't have those. We don't have access for behavioral health in the pick one area. We certainly don't have access routinely for things to support problems around transportation, food insecurity, and innovation. And so I think while we can work on that, it looks like ours can help engage our providers, educate them, teach them. I think the question we get most from our providers is, what do we do with that information once we get it? We need your help. We can identify it, but where do I send the patient? Where do I send my families once I identify that problem? And that's really the problem that I think is the most important one to solve.
Pretty eventually, it's nothing more frustrating for the providers. I find all these and what are you doing? Right? That's if you streamline that, then collecting and asking the questions.
Yeah, just one last comment on that. The resources are incredibly important to be able to solve for this. Otherwise, there's reluctance to some providers to do the screening and recognize there's a problem, but there's no way to provide a solution. And there's a real lack of not only behavioral health and primary care, but community-based organizational capacity and supports, long-term services and supports and other access points for different patient populations, patients with disabilities, seniors with challenges. There just is a lack of all of those resources available. And if we want to get upstream, part of what we're going to have to do is put in that type of a social network in order to begin to resolve what exists today before we can get upstream and try to address it and prevent it from happening in the future. So there needs to be consideration for those types of resources.
Great. To pick up on what you've all just said, and also maybe take a little bit of a step back at the same time, there's been conversation that's popped up, even amongst the four of you, and then in previous conversations around value-based contracting. And I'm wondering if you could all speak a little bit to, it seems like as a state, we have less value-based contracting with shared risk than we see in some other states, as we say, Massachusetts feels like a different planet in some ways than, what we have going on here. What is your perspective on value-based contracting? And is it facilitating, slower spending growth, higher quality, improved equity? Or could it be an impediment? Are there potential downsides to this approach? What have you seen, in the work that you're doing already?
So a couple of things. One, I think everybody agrees that that fee for service is non-sustainable and it certainly participates in a lot of the challenges that we to the payment methodology is not going to fix all license. You can end up with a full risk contract and still not move a dollar cost of an improvement involved. It is just a different way of getting paid. So it's always important as we think about it. The care delivery model has to be changed to create success that you're looking for in the family. And we've been fairly purposeful around that in terms of the work we've been doing to try and transform what we're doing on what we use sort of three big bucket form. And we've talked a lot about today, developing both need. For the places that aren't as costly as trying to do it in a care home. That's one, because if you don't give them another place to go, that's where they're gonna go. If they can't get access to a primary care, and the only things available is an ED, you're gonna need, so you need to figure out a way to make sure you meet that. That's sort of one. But the second piece is really fundamental, how do we manage chronic illness and their management teams transition from care. So basic blocking and tackling, making sure we're not dropping all these people into a very complex system. And that often leads to poor outcomes, readmissions, etc. And so that management and then ensuring that we are putting touch base with the developed care plans for those chronic disease, figure out stable and don't be compensating. And then the third is the prevention. How do we continue to build out primary care and allow them to, as you say, focus on the population? Our initiative that we've had in place for blood pressure, diabetes, in addition to diabetes as well, wasn't a medical problem. It's a logistics problem. How do we see 110,000 people with blood pressure? Because you got to see that. How do we see the 30,000 people with diabetes? At least to make sure that your office was, but then all follow up to make sure that people. It's a fundamental shift in mindset. Most clinicians say, I do really well. The people who've seen, they don't know about the thousands that they didn't see. So it's how do we get that data to them to say, you've got to check all these people, and an office visit ain't the way to do it, because it's going to be. So if we think of all of it, that system, having built that, now allowed us to move with some confidence that we know we need to do action, which is why we entered into the full risk Medicare Advantage, why we built the department plan we have. Medicare Advantage simplifies some of the payer dynamics for us to learn to make sure that we're doing the medical management, the utilization stuff that we can do, and then hopefully expand and build over. But if we were to do it the other way, we end up in full risk and we haven't built all that infrastructure, it's going to fail and then it's going to go see again. So you really, my view is that you got to be very thoughtful that you really set yourself up for success if you go through. And that's only going to address somewhat these stuff. Then it gets harder and harder and harder as we really try to move further on through.
I think, look, I'm gonna say something that sounds completely opposite of what I am and who I am. And, you know, my organization lives and breathes value-based care. And I think one of the concerns I have a little bit about the conversation today is that everybody sees that as a silver bullet, and it's not. It could actually be very dangerous if we don't do it the right way. If we assume the provider is going to take risks without any consideration for how a contract is structured, for the funding to build out advanced primary care and all the resources that were mentioned earlier today to wrap around the primary care provider, and to be able to walk in and accept that level of risk, recognizing that they are not an insurance company. All right, they're, you know, providers in this state are not sitting on a ton of risk-based capital to be able to accept significant downside risks. So there has to be contracting mechanisms that are a little more creative than what exists today in the state of Connecticut. And having been in Massachusetts with joint venture payer partnerships and working through that with payers that are interested in trying to solve this problem in Massachusetts, there was more creativity around the contracting mechanisms. In the state of Connecticut, we have a lot of national carriers, and often what happens is they get fixated on, this is our national model, this is the only way we can do it, this is the, you know, we're not going to change this, we're not going to do this. I'll give you one example. We talked a lot today about pharmacy. In all of our risk-based contracts right now, pharmacy is outstripping pretty much anything I can do on the utilization side to make up medical cost trend. It is gone from being, you know, 10 to 15% of my medical expense budget to over 30-35%. And that is not sustainable. I can work on all these patients and improve their quality, improve their health outcomes, reduce their costs and their utilization, and do that in spades on everyone that presents to me that's reasonable to have our population health tools deployed to help, and not fix the total cost of care, right? Because the pharmacy piece has been outstripping. So there has to be a solution to the pharmaceutical trend that's occurring in our country, not just in Connecticut. And then there needs to be a recognition by the plans that the work that needs to be done is different than what you would do in a fee for service environment, right? You need care managers, you need pharmacists, you need the social workers, you need health workers, you need more nurses, more PAs or NPs, whatever the practice may need to wrap around the physician so they can see a broader level of patients, create more access, and then do all of the screenings that need to be done, see them for all their annual, screenings that occur, their social determinant screenings, and be able to react to that and process that and track that. And at the same time, do a transition of care, communicate with the hospital, communicate with specialists, and the list goes on and on. And then the last component is there's got to be some work done on administrative burden for providers. And it's not just primary care, it's all providers. The constant paperwork shuffle, fill this out, sign this, do these. At least there's some work going on around quality measures in the state to try to, standardize those, which is a good effort. But we need to do more to reduce the burden of the administrative part of this work because it's becoming, it's overshadowing the amount of time a provider can spend with a patient.
I'm looking to see if anybody's read my house on it. Talk over anybody. So I appreciate these comments and, I'm hearing a lot around the idea of a fundamental shift in mindset and transformational change. And does undertaking this level and degree of change, does it necessarily have to create winners and losers within the system as we know it? And if it does, how do we manage that? Can we, move forward with all the same players kind of construed as they are, or do we need to approach this idea of transformational change in a way that's more accepting of risk, that's more accepting of things that we tend to not embrace as much because risk is kind of a scary idea when we're talking about people's health and people's well-being.
Yes, so yes, to what you said. I think value, when you're looking at value-based models, it automatically prioritizes patient. And it automatically assigns accountability, and we've all been coming to practice with transformation, leading toward value in mind for at least for us 10 years now. Does it change the players? I think that just depends on where you are and who you are, who's around the table and who are the stakeholders. And which stakeholders, because we already determined that none of us can do this alone. Which are those key components to Lisa's point, to the cost of sustaining an environment that lends itself to value, that eventually the outcome is, population health, because that's where we need to go to drive costs down, looking at preventative measures and addressing all those key things that really lead back to that. But if we're creating this environment where it's not sustainable for providers and support staff, because rather than doing what they were taught to do in medical school, which is care for your patient, we're burdening the system and the staff with, you've got to, just to Lisa's point, you've got to do this and do that. And we're very focused on chronic care management, annual wellness visits, and CCM and TCM, and there's now PCM and lots of F's. And it's all for the good reason, but that infrastructure to support those things is a cost, right? And so even though many of us, especially in a smaller organization, we wear many hats and we stretch and we try to make it work, eventually that burden becomes unsustainable. And in a time and an environment right now where recruitment of healthcare providers, in particular primary care, is extremely challenging, we have to be very creative of how we think about models that will support patient care, but also support our staff. Because we lose them, it's very difficult to replace them.
We need everybody doing this, and we need everybody that's here and everybody else in the state doing this, because if it's only one or two organizations, it's not going to help with any clinical outcomes nor cost outcomes. You're not going to see any bending of the curve. The other thing that we need to consider, and this happened in Massachusetts when Massachusetts implemented their Medicaid ACO structure. There was a recognition that there weren't enough community health workers to do what was necessary to be done. And there had to be training and education programs put in place in order to be able to build up some of those resources, which creates economic opportunity for individuals. You know, this is not easy work. And it takes it takes a team, it takes a small village, and everybody needs to be engaged in the process from the employer in certain rules and requirements for the employer, all the way down to the patient. And everybody that touches the dollar in between. Because if we follow the dollars, there's probably opportunity every single unit of the dollar to make it more efficient, to create more accountability, and to reduce waste.
One of the comments I'll make, and we started our first value-based contract 10 years ago. The first thing I want to say is, when we think about value-based care and that transition, risk-based contracting is just one of the methods and one of the techniques that we can use to drive value back to our patient population. And in the right circumstances, with the right provider groups, with the right capabilities, they can be really powerful tools to drive change. But it takes time, it takes investment, it takes resources. One thing I want to raise, and maybe I'll raise this for the group to think about is, I think that one of the fundamental questions we have to ask ourselves as here in the state or society is, what are the goals we really want to accomplish with our healthcare system? And we talk a lot about cost, and that's one of the goals. But then if I mention, well, what is the trade-off of lowering cost is changes in access and choice, or what is the impact on quality and exposure to the other parts of the system? And I think one of the problems is when we look at cost in isolation and we look at programs that are geared to cost in isolation, it loses focus on other parts of the delivery system. And there's just no way to, I think to your point, I'm not sure what you're getting at, is if we push the cost lever, it's going to have impacts on other parts of the delivery system. And to your point, in other states and other markets, they have more progressive risk-based contracting, but they have fundamentally different delivery systems. They have more significant limits on choice and patient choice about where they can go. They have narrow networks and things of that nature. And that's fine. And that's a choice that has been made in those markets. What I think we're looking for is the panacea to be able to improve access, patient satisfaction, drive quality to the highest levels, and lower costs to the lowest levels without any impact on patient choice. And that's a really challenging model that we've had. And I think, Lisa, you were alluding to this a little bit, is we need to step back and say, what are the goals we want to prioritize? How do we design our value-based plans and to best achieve those goals, knowing that there are going to be trade-offs in some of those, and there isn't a perfect program. Eventually, perhaps over time, we can evolve that. And I think this has been a question that I think we've struggled to ask. I don't think there's been a clear consensus. I think a lot of this gets decided between provider groups and insurance companies when they're negotiating contracts, rather than perhaps around a table like this, which I think is probably a better place for the question to be answered.
I think we're just learning that so great comment. And saying every system is perfectly designed to get the results you're getting, and pretty much we're looking at that. I think I heard your question a little bit. Is what's it going to take? Because we're going to continue in real tracks unless we change something. My answer is some of those things we can change. Some of them there are conditions we can't change. It's just going to be the nature, because it's a bigger decision than even the state can think. So I think the first thing in getting there is, one, I think it's going to take a wholesale rethinking of the way what patients expect for care, how they're going to get it, what we need to do to if we don't challenge ourselves to fundamentally say that's all to really get where we're going, there's gonna have to be a redesign of that. But it's going to involve much broader than the delivery system. And the question is, where are we trying to move that? But there are also going to be constraints saying, yeah, that'd be nice to change, but it won't. This is the system we've got, and that can already set some constraints to say, let's not waste a lot of time. Keep thinking about in the world that it'd be great if we could. You can't. So but we got to stay in the program. But I don't think that we can have a whole lot of what I'll say things that are non-discussable or need to be challenged as we go through that list.
Just one more comment. I agree completely with what Joe said. we need to define what value-based care is first, right? Because healthcare is local, what works for Massachusetts isn't gonna necessarily work for Connecticut, or what works in California isn't necessarily gonna work for Connecticut. But there's a lot of experimenting going on. And there's a lot of work that we can learn from. And if we would do ourselves a disservice and take that time to step back and say, what really makes sense for the state of Connecticut? We all know having a primary care provider is a good thing. Yet, what, 40% of the citizens in Connecticut don't have a primary care provider. And yet we're looking at trying to make the primary care providers accountable for maintenance costs. So we need to say, is that a decision? Is that important for us to consider? CMS and CMMI, they've done a lot of experimenting with models. There was an earlier conversation around bundles. We were one of the first in with the state of Connecticut was signifying 15 bundles. I mean, we did a lot of work on these bundles. And the biggest problem with the model is the conflict with a value-based care model that may get to a level of capitation or full risk that the population health model that is also running sideline with, oh, we're gonna do a bundle on orthopedics. Oh, we're gonna do a bundle on cardiac. We're gonna do a bundle on this. At the same time, that the primary care providers are trying to manage the patient in a population health model. There are natural economic and clinical conflicts with how those models get set up. So we want to be thoughtful about how we do that. We want to be thoughtful about what's contained within many of these models and what's not contained in these models. And then there needs to be a transition period to allow providers and payers and employers to understand that, over time, there's going to be a different healthcare consumerism in the state of Connecticut.
Great. And then this is perhaps too broad of a question, so feel free to narrow it down and address it, in whatever way you see fit. But do you have any concrete policy solutions that Connecticut should be looking at, whether it's in terms of addressing specific barriers to adopting, promising models that we've seen elsewhere, or it's making changes to to really help do that upstream approach? If you could recommend, everyone looked to you and said, what bill do we pass in 2024? What change do we make, administratively? Or there's no, magic wand or panacea, but what starts us down the right path?
I'll be very granular and raise a few specific issues and hopefully get more general. I'll just call out a couple that are actually open for discussion and things that are active issues here in the state of Connecticut, which I think will be addressed on. One I'll call out are telemedicine policies. Currently, those policies that we work with put in place, I think one of the best policies in place across the country, are about to expire and are going to need legislative action to permanently put into place. And that, as I understand, is not enacted upon this year. And now provider groups going to be going forward planning with our future about telemedicine access without any clear guidance what that's going to look like. And just the basic continuation of the status quo of these municipal providers. Proposed legislation around the high deductible plans that has been put forward. The Medical Society has put this forward numerous times, and they have great ideas and great thoughts on how to try to change some of the dynamics in that. And mostly around taking providers out of the situation of being the people responsible for collecting these high deductibles from patients when it was the insurance company's plan that was into place. And that simple switch of taking the provider out of the situation, being responsible for mitigating these thousands and thousands and thousands of dollars per company. Third thing, the conversation around prior authorization and the administrative burden of the plan. And again, we have put this forward. This has been put forward multiple times. And I think Lindsay, you mentioned that the burden on providers, I cannot understand how bad the burden is right now. And we've got pretty reasonable and pretty, I think, middle of the road language that is out there that I think would actually help mitigate some of these concerns and providers. I'm sorry, two more very specific things. I think we continue to double down on the work that we're doing to standardize our quality programs across the state. We often count this. My count up as 130, 140 different quality measures. I don't know how I really went at some point. A lot of great work is going on to standardize this so that provider groups and the state in general can have a more consolidated number quality measures that we can work upon, that I think also reflect the needs and the benefits of the state with good input from a variety of stakeholders in an open forum, which I think is the best way for this to be done. And I think the final thing I'll mention, I'll pass it upon, is the continued efforts to support information exchange. I think we've done great work to get where we are with the health information exchange across the state. I think we should continue to support those efforts and double down on those. I'd also encourage the continued support and encouragement of data exchange between local provider partners that may need to be more detailed and more intense than is needed through health information exchange, for example, a health system and its local independent provider. So there's a few very specific examples. I'll pass them.
Asking you shall receive, all right.
I think you touched on really one by the perhaps, and thank you. But I will just add, as we're talking about telemedicine and where healthcare is in terms of technology and the need to share information, and as we advance that, looking to build that into more creative models, we need to ensure that remote patient monitoring is available to all populations and not only to some. You know, especially in light of social determinants of health and the barriers that sometimes patients face. Right now, we can't do that across all patients. That's very important for us to be able to also add into the telemedicine piece. I'm going to mention this because some great work has been done recently in the last session for the 340B program, and thank you for the efforts made to help preserve that program, but there is still more work to be done there. It's a lot easier for me to tell a patient, I can get your insulin pen for $10 versus you're gonna need to go pay $335. So there is still more work to be done there, and we need to now focus on the next phase of that. And then, as we talked about a little earlier, what is needed in terms of the infrastructure to support the care delivery models and quality and ensuring that we're getting the outcomes. Again, some work has been done here in Connecticut this past session about introducing the notion of reimbursement and billing for community health workers. That role is so much less expensive than if we were to go out and get a nurse case manager. We can hire many more community health workers who are also well versed in community outreach and live out in the community for a lot less of an expense to get the job done, especially when it comes to social determinants of health and being able to address those very important issues. So those would be a couple of things that I had.
I think the only thing I would add, all great suggestions, I completely endorse everything that's been said. But I think that the one thing I would add is if we want to move in this direction towards being responsible for managing costs, then everybody has to have skin in the game. And there has to be some measurement of how much risk you're actually taking. And is there a, I don't want to necessarily suggest that everybody must take risk, but there must be some level of value-based contracting, in each provider organization, or the ones that are really out there doing all the work and really focusing on value-based care. But I do a lot of this work. There's going to be a zero-sum game because there isn't a conversation on how to really advance it in the state, and others will be spending more and more and more and more. And at the end of the day, it's not going to fix it. So is there some mandate for acceptance of risk or moving towards risk or measurement of risk, in the short term that needs to be, put forth in order to get others engaged in really accepting value-based care and certain models similar to place.
The only last basis is reducing the disruption that the role in all that process will be. I know that it's the focus. I just think that in some way keeping the partners much more together to really make sure we connect go back to insurance they have and make sure we're not suddenly increasing the doing so very where we can give most people insurance. That's a huge opportunity. I think too, we need partnership, not only community organizations, but the state actually to help to address a lot of these social determinants. I think to make sure they're recruited well, transportation documentation from it's been really helpful. It's something we could work together on as we try to solve that. And then lastly, as we think about if there is agreement that continuing to create opportunities for lower cost sites of care reduces our the cost we incur to deliver that care. If that does create opportunities, however we can expedite that as that goes forward, not to disrupt the process, but make sure we're giving the time it takes so we can have it quicker. Because I think there is lots of opportunity for that to continue to grow and really be a source of both quality, experience, and cost reduction.
Wonderful. Thank you all. Joanne, I don't know if you have one. Oh, okay. We're trying to read the microphone, sir. Thank you all for that. I'm trying to be mindful of time, but I really appreciate, all the ideas that you contributed and the positive tone and the willingness to consider new ways to deliver more affordability, better access, and high quality care to Connecticut residents. So thank you for being part of the conversation.
Thank you, Anna, and thanks to the panel very much. I'm super impressed with the specificity of your policy suggestions. We'll be expecting your language in the box. Feel free to help us with the drafting. There's some really good ideas there, and we look forward to, as we've said to all panelists today, we look forward to having you participate in further conversations. Obviously, you all are seeing this through a lens that's very proximate to the people facing the affordability challenges, and you yourselves are dealing with it. I'm just gonna not take very much time for some closing remarks, but the one thing that strikes me thinking back over the course of the day is that we did have consensus from all of our panelists that affordability is a critical issue that we need to address. So that's it, that we're going to chalk up as a success of today's proceeding, because that was one of the things that we wanted to achieve, which is, can we all agree that it is not an acceptable set of circumstances in 2023 in the state of Connecticut, one of the wealthiest states and one of the wealthiest countries, that we have people cutting their medicines in half, not seeking care because they can't afford it. We all agree that that's not an acceptable state of affairs. So that's a good thing, because that means we can all move forward together with that at the center. Jim mentioned the algorithm that sometimes attributed to Don Berwick. He said to somebody else, I don't know who originated it, but every system is perfectly designed to get the results that it gets. We have a perfectly designed system in the United States that have high cost, not such great health outcomes, difficulty with access, difficulty with workforce. Our incentives are not aligned to get what we all want, which is good health at the best possible price for our residents. And that's a simple statement and a very, very complex challenge to face, but we need to tackle it, and I think that's what today has been about. Importantly, I think as you know, I talked to our panelists, leaders in preparation for today. We talked about the things that we wanted to discuss and the things we wanted to surface, and almost each one of those conversations came back to the same thing. The incentives are not aligned. And what you were talking about, because the incentives might be there for you in this segment of the contracting, but if the larger system incentives are still driving towards volume and margin, then until that piece of the system that's driving towards value and outcomes is a larger portion of the spend, we're not going to really start to see the ship turned around. That's where our insurance industry partners really come into the conversation. And there's a lot of power there. to start accelerating these conversations around realigning the incentives, and we look forward to working with them. In some ways, we are all trapped in that system, right? We those of us who, started in medicine in the 80s and 90s, we didn't create that system. We just sort of are stuck in it. And everybody here is kind of trapped in that system of misaligned incentives. The problem, of course, is that it benefits some parties. And those are the difficult conversations that we really need to engage in. We started that today, and we will continue them. So I want to say, again, thanks to everybody who participated today, whether you're still in the room or not. I think it's been a really productive day. I'm particularly grateful to our partners from Violet, to David and Hannah and Frederick, to our team at OHS, and to all the invited witnesses who came today and took some really challenging questions and handled them really admirably. We are grateful. So with that, I think the OHS team is headed for happy hour, and we wish you a good evening.
I see. I think.